Hello, and welcome to the final webinar in our Reimagining Long-Term Care webinar series. I'm Nicole Pollock, Senior Program Lead on the Health Innovation Programs team here at Healthcare Excellence Canada. My pronouns are she, her, and I am pleased to be your host today. HEC honors the traditional territories upon which our staff and partners live, work, and play. We recognize that the standard of living that we enjoy today is the result of the stewardship and sacrifices of the original inhabitants of these territories. We must commit to not repeat past mistakes and to work towards more equitable and respectful relationships with First Nations, Inuit, and Métis. Acknowledging the territories and the original stewards of these lands is a fundamental responsibility of our organization and part of our commitment to work towards truth and reconciliation. I want to acknowledge that I'm joining you from my home office in what is now known as Ottawa, which is on the traditional, unceded, and unsurrendered territory of the Algonquin people. I recognize and deeply appreciate that their historic connection to this place and allows me the privilege to be here today. So I invite you to share who you are and where you're joining from in the chat box. We are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point during the webinar in English or French. If you have a comment or question, please type it into the chat box. We'll look to address as many of your questions as possible during the Q&A session near the end of the webinar. If you need support at any time during the webinar, you can reach out to our tech support using the chat feature. This session is being recorded and will be available on our website in the next couple of days to review or share with any colleagues who may have missed it. I'm excited to welcome our speakers for today from the Canadian Institute for Health Information. Jacqueline Smith-Bell is the team lead for clinical standards and training for specialized care standards and engagement at CIHI. Jacqueline leads strategic and operational activities related to the development, promotion, education, and implementation in the use of specialized care data standards and standardized assessments across Canada. Her experience in healthcare project management, health policy and procedures, information management, and information technology systems and standards has enabled her to manage system change and integration. Also welcome to Patricia Hanna. She's a clinical specialist at CIHI. She currently supports the use and implementation of the Inter-I long-term care assessments in Canada by providing education on the standards of collection and use of clinical and organizational outputs. With over 30 years of experience in health information management as well as nursing, Patricia has held various positions. As a former classification specialist at CIHI, Patricia was involved in the development and enhancement of the acute and ambulatory grouping methodologies. Prior to joining CIHI, Patricia was a clinical trials research associate and coordinated several protocols in oncology at the Ottawa Regional Cancer Centre. Patricia is dedicated to excellence in healthcare data and data usage that can lead to better care decisions and outcomes for Canadians. So once again, feel free to drop questions into the chat box throughout the presentation, and over to our speakers.
Good morning, or maybe afternoon for some across the country in the East. Thank you for having us today. So both Pat and I work in the specialized care branch at the Canadian Institute for Health Information, or better known as CIHI, where we work to collect and report information from the mental health, home care, long-term care, and rehabilitation sectors. We are both on the clinical team, and our role is to provide education on assessment data collection, associated outputs, and their uses. We provide clinical client support, and we create and maintain documentation such as job aids, reference guides, and we have a newsletter, and we support the implementation of the new suite of Inter-I assessments across Canada. And I'm going to take a moment here if we can launch our first two polls just to find out where everyone is coming from and what your knowledge is about quality indicators today. So our first poll question is, have you heard about long-term care quality indicators? And our second question is, do you work in a long-term care setting? We recognize that a number of healthcare individuals come from all over in all different sectors. So we're just interested to know if you are coming to us today from a long-term care setting. Great. And maybe we can show the results. Great. So we've got lots of knowledge about long-term care quality indicators. I hope this session will be useful for you. And we have about half the participants today, or the audience, who are coming to us from a long-term care setting. So thank you. Next slide, please. So CIHI is on a learning journey guided by what we have learned and continue to learn from Indigenous peoples, communities, governments, and organizations. We are engaging First Nations, Inuit, and Métis peoples to support their health, wellness, and data priorities as defined by them. We acknowledge and understand that our work is grounded in cultural safety and humility, driven by relationships and partnerships, and built on respectful engagement. As CIHI works toward better health for all people in Canada, and we acknowledge that we live and work on the traditional territories of First Nations, Inuit, and Métis peoples across the country. We come to you today, both Pat and I, from the traditional and ancestral territories of the Anishinaabe, Haudenosaunee, Huron-Wendat, and Métis people. Next slide, please. So today we will cover the CIHI and Inter-Rai relationship, our long-term care assessments and reporting systems, quality indicators derived from the data collected in those assessments, CIHI secure and public reporting, and how these quality indicators can be used to improve care. Next slide, please. So let's introduce you to CIHI and our partner Inter-Rai. Next slide. So who is CIHI? So we are an independent, not-for-profit organization dedicated to providing comparable and actionable data and information that's used to accelerate improvements in healthcare, health system performance, and population health across Canada. We have over 700 plus employees who work closely with federal, provincial, and territorial partners and stakeholders across Canada to collect, package, and distribute data and information on topics such as mental health, substance use, health spending, workforce, and COVID-19. This information helps inform health policy management, care, and research across the country. For more than 25 years, CIHI has set the pace on data privacy, security, accessibility, and innovation to improve Canada's health systems. CIHI, better data, better decisions, healthier Canadians. And pictured here are our two main offices in Ottawa and Toronto, and we have regional offices as well in Victoria and Montreal. Next slide, please. So who is Inter-Rai? Inter-Rai is a collaborative network of researchers and practitioners in over 35 countries around the world, committed to improving care for persons who are disabled or medically complex. Their network strives to promote evidence-informed clinical practice and policy decision-making. CIHI works in partnership with Inter-Rai in the development, implementation, collection, analysis, and reporting of Inter-Rai data. Next slide. So the CIHI Inter-Rai partnership. CIHI has had a long-standing partnership with Inter-Rai, and we work closely together to develop the instruments for use in Canada. And this includes longitudinal data integrity elements, such as Indigenous elements, sex and gender, etc. We work with Inter-Rai to develop the algorithms, which we then transform to pseudocode and test data for our vendors. We license vendors for products such as submission specifications to develop and test their systems, and we enable vendor systems to submit data to CIHI once they've met these requirements. CIHI also develops the validations to link the assessment information together, so the use of valid values, longitudinal data integrity checks, dates, formats, etc. And we report on the assessment information at a pan-Canadian level in products such as e-reports and your health system. CIHI develops multiple types of education products on how to code the assessment, how to submit the data to CIHI, and how to use the information at different levels for decision making. In addition, we provide ongoing support to the participating jurisdictions with e-query and centralized emails to respond to questions from stakeholders. Next slide, please. So now I will hand it over to Pat to discuss our long-term care assessments and reporting systems.
Thank you, Jacqueline. So before getting into quality indicators, I'd like to provide you first an overview of the assessments and reporting systems for long-term care that we support at CIHI. The assessment information that we receive actually feed into those quality indicators. Next slide, please. So currently, CIHI receives data from two different long-term care inter-I assessments, meaning we support two instrument standards and reporting systems. RIMDS assessment data are submitted in CCRS. RIMDS 2.0 and CCRS represents the legacy system that's been used at CIHI for more than 15 years. We also receive inter-I LTCF assessment data into the newer CIHI reporting system called the Integrated Inter-I Reporting System. This system is near real time for submission and is integrated in the sense that it can also receive inter-I assessment data not only from the long-term care sector, but from home care, for example. The first province to adopt and submit was New Brunswick around 2016. So there is a process underway for jurisdictions to transition from RIMDS 2.0 to inter-I LTCF. Eventually, the CCRS will be decommissioned in April 2016, and only inter-I LTCF assessment data will be received at CIHI. So whether we're looking at RIMDS 2.0 or inter-I LTCF, assessments are completed in long-term care for each person on admission and on a quarterly basis following their admission. So the data is longitudinal, which allows us to follow the status of individuals over the course of their stay in long-term care. So the assessment has a holistic approach and provides information not only on the clinical status of people, but also on their mental, physical functioning, psychosocial well-being, as well as treatments and interventions they receive. So on this slide, we are depicting the user manual for both of those instruments. Next slide. So as I mentioned, there is a transition process underway for jurisdictions to either adopt the instrument or transition from RIMDS 2.0 to inter-I LTCF. So the map here depicts the implementation status of the inter-I LTCF by province, territory, and region as of September of this year. So Saskatchewan, New Brunswick, and Nova Scotia have fully implemented the inter-I LTCF and are submitting data into the IRIS system at CIHI. Alberta has started collecting data in many facilities, while some are still using MDS. Alberta has started, Yukon and Northwest Territories are in the process of implementing, and British Columbia, Manitoba, Ontario, as well as PEI and Newfoundland are planning to implement. CIHI has a dedicated team to assist in this process. Next slide, please. Next slide, please. Oh, I'm sorry. Let's just go back one. So client-centered through an inter-I assessment, 4 groups of clinical outputs are derived and generated from a completed inter-I assessment, which are then used by different levels in the health system. So the person is assessed at point of care. These outputs include outcome scales and clinical assessment protocols that are used for care planning. And below are the quality indicators and the resource utilization groups that form the case mix system, which are more of interest to managers and directors of care. Next slide, please. So what are quality indicators and how are they calculated? Next slide. Long-term care quality indicators were developed by inter-I. inter quality indicators are used worldwide, including Canada. CIHI supports the use of quality indicators by providing information and reporting. So QIs are pointers that indicate potential areas in care that need further review and investigation, and they are meant to improve care. So care providers and governments use quality indicators to monitor and improve the quality of care within and across organizations. So there are prevalence and incidence indicators. So our prevalence indicators measure the status of the person at a given point in time in the long-term care facility, while incidence indicators will measure change in that person's function or status since their previous assessment. So QIs measure quality across key areas of safety, health status, physical and mental function. So there are a total of 35 quality indicators that apply to the legacy instrument and 34 in the new suite inter-ILTCF assessment. So examples include percentage of residents who've had a fall in the last 30 days, percentage of residents with worsened mood, those with having pain or skin ulcers, and we also have incident indicators that actually indicate improvement. So with that, we're going to launch our first two polls on this topic. So I'll just ask that we do that right now. So I have a couple of questions here. So having said what I said, would a 0% rate in a quality indicator be realistic for a facility to achieve? And my second question would be, do you think quality indicators reflect poor or inadequate care? So I'll give you a few moments to complete that poll. And once we have most of the responses in, I'll ask our support person to show the results of those questions. So I'm pleased to see that most of you have responded no, which is correct. So it's not realistic to achieve a 0% rate in terms of safety, clinical issues, or mental issues in any prevalence or worsen indicators. That's just not possible to do. And do quality indicators reflect poor care? Absolutely not. There are factors that are going to be out of a facility's control. We'll always have individuals in any facility who are more at risk of falls, worsening condition, and so on. So the complexity of residents or the resident population of a facility will have an impact on all of that. So remember that quality indicators are not meant to be punitive or to flag poor care. They are meant for us to take a closer look to find initiatives to improve care. And I also mentioned that we do have indicators that focus on improvement. So a high percentage in those indicators is a really good thing. So next slide, please. So let's take a look at the calculation of a quality indicator. So a quality indicator represents a particular item or items coded from a completed assessment. Click. Over what we call valid assessments. Click. So the assessment has to be valid for the calculation to be fair and meaningful. So what does a valid assessment mean? Click. It means that we're not going to count an admission or a first assessment. So it wouldn't be reasonable to include something that happened fairly recently to the resident's admission to the facility or before their admission. And there are also indicator-specific exclusion criteria. This typically represents certain conditions that a resident has, and for that reason, shouldn't be counted and included in the calculation. So an example of exclusions for many quality indicators are residents identified as in end of life or they are currently under hospice care. So 2 assessments are required to calculate an incidence indicator. And when we multiply by 100, it simply provides us a percentage or a rate. So that's the basic calculation of a quality indicator. Next slide, please. So the following is an example of one of the quality indicators that we have called the potentially inappropriate use of antipsychotics. So the indicator is the item that captures the use of antipsychotics during the observation period of the assessment. Click. So in this case, it's antipsychotics and neuroleptics coded as being received between 1 and 7 days of the assessment period. So the exclusions on the right are specific to this quality indicator. Assessments with one or more of these items coded as present and applicable to the resident won't be counted in the calculations. So for examples, individuals identified as having a diagnosis of schizophrenia or Huntington's will be excluded. Those exhibiting delusions or hallucinations during the assessment period are also going to be excluded. And finally, what I've mentioned before, individuals identified as being in end-stage disease or receiving hospice or palliative care. So those particular items would be excluded from the calculation. So this is in addition to the basic exclusion of excluding admission assessments. Next slide, please. So let's take a look at this depiction of residents under our fictitious West Hill home to see how this works. So completed admission assessments of residents in the reporting period are going to be excluded, as well as those assessments with one or more of those coded items being present as indicator-specific exclusions that we mentioned earlier. Click. So what are left are 9 valid eligible assessments. Click. Only 3 out of the 9, click, are going to be included and counted in the quality indicator calculation because, click, antipsychotics is coded as having been used in the last 7 days, and there are no exclusions coded on those assessments. Next slide, please. Previous slide, please. Thank you. QIs are intended to measure the quality of care delivered in long-term care facilities. However, some factors are beyond the facility's control, even though they affect resident outcomes. So as a result, some facilities will appear to have poor performance levels than others, but only because they have more higher risk residents. To enable more appropriate and fair comparisons of the actual quality of care, these population differences need to be taken into account through a process of what we call risk adjustment. So the risk adjustment methodology compares the risk profile of the resident population in an individual facility, organization, or jurisdiction with the profile of a standard reference population, and then modifies the quality indicator result for that facility, organization, or jurisdiction. So it's relative to a standard reference population. So we do have a CIHI document that provides details on the methodology of standardization, and it's entitled CCRS Quality Indicator Risk Adjustment Methodology. It also applies to the IRIS system. Next slide, please. So adjustments are made for each facility, which looks at the resident population as a whole. So when we adjust at a facility level, stratas are applied, which arranges and sorts all the residents in the facility into high, medium, and low risk groups based on a calculation. And one of these, for example, may be case mix index, which represents the intensity of care of some of these clinical resident groupings. Adjustments are also made on certain individual characteristics of residents, such as age, certain diagnoses, health conditions, and other factors. Each quality indicator has its own type of adjustment. So this bar graph is a depiction of 5 facilities of risk adjusting. So the dark green represents the risk adjusted rates, while the teal represents the actual unadjusted quality rates of those facilities. So part of adjusting the rates is to remove extreme cases. And to put it into simple terms, it's a method of leveling the playing field for fair comparisons between QI results, between facilities, regions and provinces. So adjusted rates fluctuate. They can increase, they can decrease depending on changes based on a facility's profile and resident characteristics. Next slide, please. So CIHI provides or produces several reports on various healthcare sectors and topics. In particular, CIHI provides private, secure, and public reports about long-term care indicators. Next slide, please. So the private secure reports, CCRS and IRIS reports, are the ones that only registered users with a profile at CIHI and affiliation to a submitting facility will have access to. As a registered user affiliated to a submitting facility, I will be able to examine my own facility's adjusted and unadjusted rates of quality indicators, as well as those from other facilities, corporations, and provinces that submit to the same reporting system. So IRIS, for example, IRIS reports apply to New Brunswick, Nova Scotia, and Saskatchewan that currently submit data in IRIS, so they can see each other's results. In the public domain, there are a subset of quality indicators that are available to view from our CIHI website. So we have the quick stats and what we call your health system. Next slide, please. So this image is actually the landing page to our new private IRIS reports that are available to registered users from New Brunswick, Nova Scotia, and Saskatchewan. So registered users who submit intra-LTCF data to us will have access to their quality indicator results, as well as those from other facilities, corporations, and provinces from all of those three provinces. So the report application allows users to access interactive visualizations to support comparisons, trending, geospatial analysis of quality indicators. And in addition to QIs, facilities are also able to examine other clinical outputs, such as case mix, outcome scales, in addition to contextual measures. Next slide, please. So quick stats is something that's publicly reported. Tables are produced and released every September and reports on the previous fiscal year. So the quick stats intended audiences are the public, media, and researchers. In addition to reporting on 19 quality indicators by province, territory, and total, quick stats also include frequently requested long-term care metrics such as age, where residents were admitted from, disease diagnoses, treatments and procedures, and so much more. So the 2022-2023 were released just this past September. Next slide, please. So Your Health System, or YHS, is also public and is front-facing on the CIHI website. It reports on many quality indicators in various healthcare sectors. So for long-term care, it reports on 9 of our quality indicators. So Your Health System public website displays information at the facility level. Contextual measures gives an overview of each facility or home. It allows to add facilities with regional and provincial national comparators. It also shows trending of quality indicators over time by fiscal year. Risk adjustment is applied to YHS publicly reported indicators for better comparison, meaning that our public sees only the adjusted rates of those quality indicators. And the data for YHS will be refreshed this next month in December with the 2022-2023 data. Next slide, please. So I'm now going to turn it over to Jacqueline to speak to you about how to use quality indicators to improve care.
Great, thank you, Pat. And so we're going to put all this information together. So let's go to the next slide. So we reviewed quality indicators generated from the assessment and how they can be accessed both privately within your own facility data and publicly in CIHI reporting, such as Your Health System. So using the information, you you can support performance improvement in your organization by creating quality improvement initiatives and plans. And the next two slides are sort of a quality improvement methodology that I am most familiar with, but there may be others that you may be using. So I'm just wanted to put that out there. So for example, click. Oh, no, back to the slide. I think everything's on this slide, so don't worry about it. So you'll want it. So first off is the aim, your aim statement. So you'll want to determine your aim statement. Where can you improve? By reviewing CIHI's performance reports and comparable data. You can look at the comparable data, and you may want to drill down to look at other facilities or organizations that have shown improvement or better rates than you are. And you may want to get in touch with these facilities and find out what improvement plans or processes they have in place to give them those lower rates. Next, you would have your measurement, and you want to create your plan by looking at ways you can improve and establishing meaningful targets using report data. And again, you can take a look at the CIHI's comparable data and look at where is a median target, for example, and maybe that might be your goal when you're setting a target. And then lastly, how will you track your progress? So CIHI provides, again, those quarterly reports for facilities. You may want to review the indicator criteria. You may want to review the numerator and denominators of the indicator to determine which residents are being included, and then do a deeper dive to understand the who and the why. And you want to determine how you're going to share that progress with others at all levels of your organization. So this may be a QI board in the home. We've all seen those. But you might even want to drill down the results to the unit level and have unit by unit comparison. That's very meaningful for the staff to get engaged. And it's important to get buy-in on the quality of the data in your facility and organization. So by sharing the results, you may get some questions about the data quality, and you may be doing a deeper dive into how you're collecting that particular data. Next slide. So here's just an example of a quality improvement plan using CIHI quality indicators. Two quality indicators have been chosen for the aim statement. So you'll see here to reduce inappropriate use of antipsychotics and to reduce the number of resident falls in both in long-term care. So what do we want to improve or aim for? Then where you want to know how we're going to measure and what's our source. So we measure the QI rates on, for example, antipsychotic use using the quality indicator in the LTCF e-reports. In this example, the current performance is 40% in Q2, and the target we want to achieve is 35%, and to realize a greater than 10% improvement. So those results are provided quarterly, so it can be monitored quarterly. And how are we going to track that change? Tracking the process will be by reviewing the right assessments and looking where we fit by comparing ourselves to provincial and national levels overall for that particular QI, identifying peer facilities to compare ourselves with and to trend. And the goal must be obviously time limited and achievable. And in this example, it's by March. Next slide, please. And this slide is just an example of some national trending. So the graph here represents QIs, can represent QIs with noteworthy improvements over time at a national level. This is from fiscal year 2013 to fiscal year 2019 and beyond. So for potentially inappropriate use of antipsychotics in long-term care over time, you can see we were at 30% when the initiative and the indicator first sort of was published and started getting some attention. And through the review of that quality indicator data and quality improvement initiatives, that rate was on the decline. So there was a slow decline in the inappropriate use, potentially inappropriate use of antipsychotics. So 33% relative decrease. But we did see with an increase from 2020 to 2022. And I think that's mostly likely due to COVID-19 and probably your organization, or you've seen a lot more review of the potentially inappropriate use of antipsychotics because it's coming back into the media and the limelight, into our clinical care because of the use of those potentially inappropriate use of those antipsychotics during the COVID-19 and through the lockdowns. So that's just an example of how you could trend and how we're trending nationally. And I'm going to hand it back to Pat to talk a little bit about resources.
Thank you, Jacqueline. So I'm just going to take a quick peek about what we have in terms of resources at CIHI. So next slide, please. So one thing that we do have directly on our CIHI website is what we call an indicator library webpage. And by selecting long-term care under types of care, you'll be able to view 14 of the 34 or 35 long-term care indicators. And it features the title of the indicator and description, background interpretations and benchmarks, available data results by year and geographic coverage, the calculation, which is important, what it includes, what it excludes, and the adjustments that are applied for risk adjustment, and some of the caveats and limitations, and as well as references to those. Next slide, please. So having said that, for more information, or if you have very detailed information or detailed questions about the methodology or any of our indicators, you can certainly reach us at specializedcare@cihi.ca. So with that, I believe we are at the point of taking questions, I believe. So I will turn it over to our moderator.
That's wonderful. Thank you, Patricia. Thank you both for this wonderful presentation. I think you did a great job of synthesizing a lot of information in a short period of time in a really understandable way. So thank you for that. Once again, we'll have some time for questions now. So if there's any from participants, please feel free to type them into the chat box, and we'll have a bit of a discussion. So maybe just to get us started, Patricia, while I have you here on the screen, you had a really good example early on in the presentation about the potentially inappropriate use of antipsychotics. So it showed sort of, out of all the residents, when assessments should be excluded and when they are valid and counted. So wondering if you could expand on that terminology and why CIHI uses for this quality indicator the potentially inappropriate use, and unpack what that means.
Sure, absolutely. So first thing, when we're looking at our quality indicators, they were developed by Interoi. And you'll notice as well that the indicator doesn't include all psychiatric disorders. Okay, so not all of them were considered as exclusions for this quality indicator. And Interoi really based their selection of these based on an odds ratio for how it related to the outcome. So it's very statistical. So for instance, sometimes you'll see people that are prescribed antipsychotics for other reasons, such as bipolar disorder, for instance. So they didn't include that because there wasn't a lot of those kinds of individuals in long-term care. So they didn't meet the threshold for their methodology. Now, having said that, one thing that does exclude someone out of this quality indicator are individuals who exhibit delusions or hallucinations during the observation period. So these individuals would, their assessments would be excluded. And another thing to keep in mind about this quality indicator is that it was never developed to address off-label use of antipsychotics or use such as an adjunct to antidepressant drug therapy that we're seeing a lot in commercials lately. And remember that this indicator, the label of it, it's potentially inappropriate. We're not saying it's inappropriate, it's potentially inappropriate. So one thing to keep in mind about these antipsychotic medications is that there's a lot of side effects associated to them, such as balance issues, which could make older individuals or more frail people at risk of falls. It can affect quality of life. There's all kinds of things that can occur. Tardive dyskinesia is another one I can think of. I'm trying to think of something else here. But having said that, the effects of these medications are a little harder on older individuals. And really the point is that we want to take a look at folks that maybe are taking these and are not getting excluded from the calculation and see, well, do we really is it absolutely necessary that they have to be on those antipsychotics? So maybe there are other interventions we can do, or other approaches to control behaviors or those kinds of things. And also, having said that, Jacqueline also was presenting the fact that there was an uptick in use during COVID. So there's a lot of theory about why that could have been, like after, the people that are admitted with them. It takes a while to wean people off of those medications as well. So there's a lot of different factors that can actually show an uptick in those results. So I don't know if there was any other questions that we can address. I'll just turn it over to Joanna if there's anything else.
Thanks, Patricia. Yeah, just waiting. A few questions came in, and thank you to Jacqueline for answering some of them throughout the presentation. I'm wondering, Patricia, if you can speak a bit more about, perhaps related to that indicator or other quality indicators, about any suggestions to improve data quality in the long-term care sector.
So one of the things is to basically do a deeper dive in your own facility's reports and maybe tease out those who have triggered the particular quality indicator and try to sort of find out why this is happening. There's a lot of communities of practice that share their interventions or their ideas. So there's this whole idea of sharing initiatives of how we can reduce some, for falls, for instance. We can learn a lot from what other facilities have implemented to reduce falls, for instance. So so communities of practice that can share what they do in their own facilities with others. So that's a great way to to reduce, rates that way. I don't know if there's any other questions.
Hi there, Pat. There's a question in the chat about where you can find community of practices for long-term care. So each province, and I'm sure there's some local, regional communities of practice. Get in touch with your colleagues. If you have a provincial contact.
I think Jacqueline cut out for me. I don't know, Patricia, if you wanted to continue there.
Yes, so it does vary from province to province. There are some. Here, she's back.
Okay, or maybe develop your own. Start your own.
Thanks,
Jacqueline. It cut out there for a minute, but
for instance, in British Columbia, I could add to that. They have a clinical working group, and they meet every month. And because the way British Columbia is organized, they have different regions. So that's a great way to connect and learn what's going on in different regions and what they're doing. So I encourage other provinces to do the same. especially Ontario as well. Like in Ontario, eventually we are moving to inter-isle TCF at some point, and that would be great. So sometimes we have to start our own. So
Great, thank you. We often get questions about the timeliness of data and when it's reported from a home to CIHI, particularly, for example, where you gave the great examples about the quality improvement plans, right? And so if they're submitting the data and the ability to use that to both monitor their own progress and as a comparator to provincial or national levels. So it's a common question, wondering if there are any opportunities, in the near future, to be able to access more real-time data.
I can probably answer that. So the new system IRIS is designed so that each assessment is completed and can be sent to CIHI directly. And it uses, if any of those techies out there, it uses FHIR HL7 messaging standard technology, which is an interoperable standard that allows systems to communicate with each other, basically. So with that system, it's near real-time data submission. There's no end of quarter submission deadlines, or if you previously are batching your assessments, there's no need for that. It just automatically can go to the IRIS system. And then our new IRIS secure reporting for long-term care, all those reports will be refreshed monthly. So those are right now, those are for jurisdictions who have implemented the new assessment and are submitting data to IRIS now. So they have access to it. All reports are refreshed monthly. And then the quarterly results are available earlier than normal. So there was quite a lag, as you can know, in the current system. So typically the results are available within 5 weeks of the end of the fiscal quarter. So significant reduction in, so hopefully we'll get all that data in by the end of the quarter, gives us some time to massage the data and prepare the reports, and then approximately 5 weeks, a month after, you would get your data. So a lot quicker than the old system. So it's a definite improvement.
That's great to hear. Thanks, Jacqueline. Still seeing lots of chatting in the chat box, and thanks, Jacqueline, for monitoring and answering and providing links as you go. Here's a new question popping up. Any study or findings on equity and long-term care?
I will turn that one over to Jacqueline.
Yeah, we're actually rolling out and looking at our sort of standard data collection on equity. So that's still in the works, and we'll probably look to implement. And I know Inter has sort of some data elements in their new work regarding that. So we'll probably be looking at that for the Canadian context and implementing it in the future. And then we'll be able to have the data. And once we have the data, we'll be able to do some studies. So
that's great. Thank you. Curious if there are any types of new long-term care indicators that CIHI is working on, any new additions to come down the line that you can share at this point?
Well, in terms of the indicators that we spoke about today, those are inter-isle. So remember that those long-term care indicators were developed by inter-isle. So if they decide to modify or add indicators, it would probably come from them because it's interfaced with their instrument. Now, in terms of actual CIHI indicators, I see a note about the shared health priorities indicators, and I'm going to turn it over to Jacqueline if you've heard anything at all of any new things coming down.
I believe there are some new ones that we're working on and that we've been funded to work on across the country. I would suggest you can send us an email at specializedcare@cihi.ca, or just search our website on shared health priorities, and you'll probably get the most recent updates on those. And if you're looking at a lot of that data is in your health system as well, those shared health priority, the ones that we are currently reporting on.
Okay, great, thanks. So a question from the chat box: are all long-term care communities required or encouraged to have quality improvement plans? Not sure if you addressed that in the chat box, Jacqueline.
Yeah, I think I addressed it in the chat box. So we do know of some provinces that are, mandating certain quality indicators for review and submission, and kind of reviewing those as sort of a whole, as a provincial initiative or mandate. But that's really up to your region or your area. But that's also to say that quality improvement is a great process, and you can certainly pick it up on your own in the home and look at anything that needs to be improved. If you have a problem or you need something that needs to be reviewed and you think it can be improved upon, then start using that quality improvement process and just walking through it and thinking of ideas. I think we probably do it without maybe that formal anyways, thinking of and documenting it, but what are the ideas to help improve that, and brainstorming what are those ideas to improve that. And then part of the quality improvement process that we don't talk about here is the testing of it, right? You're going to test that process and see if it's made a difference, or if it's impacted another quality indicator as well, right? So you might look at restraints, but now you have an increase in falls, right? So you have to look at sort of all of them in play when you do an initiative and you work out sort of your plans. But then you just kind of go back to the drawing board and then try to relook at what can we do again. So I would encourage anyone, it's a great process to do. Sometimes there's a lot of information on the websites and in the provincial websites as well and there's probably, I think most provinces have a health quality council or health quality group that you could probably tap into what that province looks, what type of methodology and how they look at quality improvement.
Mm-hmm. And you're speaking our language here in Healthcare Excellence Canada. So I think this somewhat relates to the timeliness question earlier. If our organization supports long-term care sector to improve their specific domains of the QI plans, physical, cognitive, social domains, are we able to access these data pre and post implementation? So I wonder if they're looking for a way to kind of access their data or work with CIHI to see the before and after.
So the current system, CCRS, and the new system, IRIS, are completely two separate systems. So one will be turned off basically or stopped and no longer supported, and will continue with the IRIS. There is the ability in eReports to download your report. So I would suggest you download your reports as they come so that you have your own repository of those to look back on. And then we also do data requests. So if you don't happen to do that and you get stuck, we do have a data request process where we can do some ad hoc data requests for you. There's a process for that.
Right, thanks. So I guess a question about the history of how CIHI became so integrated with Inter-RAI. Can you describe the process by which you worked with Inter-RAI to develop indicators that are fit for the objectives?
So I don't know. So I think Inter-RAI and CIHI have been entwined for quite some time, as long as I've been, sort of working with, in my previous role, I've always worked with CIHI for about over 15 years. So it's always been there. But as far as the process, we work really closely with Inter-RAI Canada and with the fellow and with the organization in Canada on their research and what they do. But they do have an international community. And so the international community is a number of researchers and clinicians of all types that work on the creation and the review of all this information and all these indicators and the assessments. And they do constant reviews, and we can bring questions to that group as well, and they review those things. And then once those have been determined what that is, so the quality indicator is, kind of the methodology, is determined, we do have a conversation with Interi before we implement anything at CIHI to really look if it's fit for the Canadian context, if the language surrounding the quality indicator, and I've seen your facility comments, so I will bring that back. If the language is suitable for the Canadian context before, and then we also have a large stakeholder consultation process where we inform our stakeholders. We have advisory group members and key contacts in all the provinces where we would discuss the indicator or any changes to the indicator, get their feedback, and involve them in the process before we actually publish any specifications for vendors and make it public for use.
And there was actually a question related to that around how does CIHI actively engage the public to help ensure they are informed and understand the reports?
Yeah, we have advisory committees, and then we'll just do ad hoc stakeholder consultations. So we have key contacts in all the provinces and territories for the sectors, and we'll reach out, and they usually kind of reach out depending on the topic to other people. We recently had a consultation on the maple and home care, and we had over 40 people from across the province weigh in on the changes for that maple algorithm in the home care setting. So we do ad hoc. So you may in some days in the future be invited somehow to one of these stakeholder consultations.
That's great. Thank you. Interesting question about any targets for the quality indicators for the long-term care home.
So we don't necessarily set the target. We just publish the rates. It's really up to the home to set the target, and then really to look at, what is the Canadian rate? What are the provincial rates? What are the rates for long-term care homes that are similar to mine? So size and unit types, and then kind of drilling down from that, and then looking comparably what's really achievable, because that's also the key, is not to set a target. So look at that, but then don't set a target that you're not going to reach maybe this year, or maybe it's just 5% better or 2% better this year. And maybe in the long term, it's like 10%, but right now we're going to try for 2%. So it's incremental, right? So looking at what's possible and what is out there already.
Yeah.
One of the features of the reports is being able to select peers. So, do you want to compare yourself to just urban, size of your facility, and what we call case mix is your complexity of the people within your facility. Like pick somebody that looks like you. So, you can't, everybody's so different. So that's a way also to create yourself a target as well. So selecting peers that are similar to you in terms of a facility is important.
Yeah, great tip. So we have time maybe for one more quick question. Is there any way to determine the residents' well-being or mental health in addition to the physical indicators?
So you're talking about their well-being. Can you repeat the question?
Is there any way to determine the residents' well-being or mental health in addition to the physical indicators? And it does make me think of, go ahead.
Yeah, so we do. Yeah, so we have worsened mood, quality indicator. We actually have improved mood, quality indicator. So right there we have those that look at items from the assessment that look at indicators of depression and those kinds of things. So those are indicators we can look at more closely to determine their mental well-being that way. Mm-hmm. So those are a couple of indicators that are available.
Okay, great. Thanks. And any last word from you, Jacqueline?
No, thank you for having us. I think if you have any additional questions, I've put in, send us an email at specializedcare@cihi.ca. We can connect you to who we know, our contacts for community of practice, or any other information that you may want or access that you need. We can answer it ourselves, or we can send it to the right team to answer your questions.
That's wonderful. Thank you. And thank you both so much again for your presentation, and to the audience for your active participation and questions. So this is the final webinar in our Reimagining Long-Term Care series, and we hope you enjoyed it throughout the calendar year. Thank you so much for joining us. If you would like to keep up to date on our future programs and the related long-term care sector work we do, make sure to visit the HEC website and sign up for our newsletter. So although this is our final webinar, we would still really appreciate your feedback, and thanks for participating in the polls throughout. So one final poll for you today. If you could answer the questions on your screen about whether the webinar provided useful information, if you intend to share what you've learned, that you now know more about this topic than you did before participating. And lastly, our funder, Health Canada, does require that we ask these optional questions around how you identify in terms of gender. I'll leave that up for a minute, but thank you again. And this will conclude our event. Thank you so much for coming. Have a great day, everyone.